Welcome back to the Urology Care Podcast. Today we're going to be talking about an issue and a condition that you may not be familiar with, but we think it's important to inform you guys on this one, and I have a very special guest today. I'm going to let him introduce himself now and explain what he does.
My name is Bud Burnett, Arthur Burnett officially, and I'm a professor of urology at Johns Hopkins University School of Medicine, on staff with the urology department, and I specialize in aspects of male sexual health, including Peyronie's disease. So Peyronie's disease refers to a deformity of the penis that we typically think of as being acquired. Mm-hmm. So it's something that we associate with being alive for some period of time. It's not something that you're born with, but it's a condition that whereby the penis does develop some sort of structural changes in it. Mm-hmm. That we're still defining, but it does affect men typically in the adult age range, and commonly then leads to an inability to perform sexually with the penis, male organ, because of this deformity that develops.
Can you explain what the deformity is?
So the deformity is scarring in the penis, oftentimes with penile angulation or shortening, with this scar tissue that can also then interfere with the ability to achieve erections. So it is a condition then that has a structural impact on the penis, but also a functional impact on the penis, and therefore does interfere with how a person can go about sexual activity. Now, it also has a psychological component too. Mm-hmm. So understandably, for a person who has this kind of deformity that develops within the penis, it can impact a person not just physically, but also psychologically and emotionally.
So how would you know if you have it maybe in its early stages?
Well, it's a condition that you know it based on observing in yourself the changes of your penis. The penis may have been at some earlier stage in life, at least in the flaccid state, relatively soft and not deformed in some way. But then if you start to appreciate that the penis acquires some scar tissue in it, you can feel some gristle or scar tissue yourself, that your penis becomes angulated or shortened when you get an erection, or you have trouble getting an erection that seems to be associated with this scarring process, then that's how you may pick up that you have this condition. Well, I think that you know it, the way you know that you have this condition is based on your own observation or your partner's observation, that your penis is deformed from what you perhaps had known earlier. And as I mentioned, it's acquired, so you may have had at least a reference point earlier in life to know how your penis seemed to have been. And then if you develop the scar tissue within the penis, it's not on the surface of the penis. This is a condition within the structure of the penis now that you can observe is not normal in terms of either how you knew your penis would lengthen and expand and get a normal appearing erection. If it's now angulated or shortened, that's really an observation that you may be able to make. Now, when this condition develops, which is another part of the conversation here, oftentimes men will have pain sensations because of this development of the problem. That we think could result from a traumatic effect in the penis. During the course of life, a person may have some sexual activity or what have you, that the penis may get traumatized, and you develop this scarring with kind of an inflammatory process, inflammation, much like a sprained knee or a twisted ankle or something of that sort. Maybe that's one way to kind of think of what's going on here. The condition is benign, it's not cancerous. But in the development of this, it goes through kind of a natural history of where you may initially observe that something's not right with my penis. And I feel some pain sensations when I'm getting an erection, even attempting intercourse, and it just is, I hadn't felt like this before. It's hurtful. And then it goes through a process of active inflammation that eventually goes towards a stable phase of it that may be a few months down the line. And then you're left then maybe with this angulation and changes in your erection quality the pain sensations may lessen by that time.
Yeah.
But then you know that there's something really different about the penis.
Would you only feel the pain during the erections, or would it happen without that?
Well, it can happen without it, because the inflammatory process can create these sensations that are, again, hurtful. So that it may not be pain per se, but may not be a sensation that feels comfortable in any sort of way. It may actually be more pronounced, though, when you do start to get an erection, because the scarring may tether the penis, the structure within the penis being a very specialized organ of the body that has some elasticity to it, and a structure of the penis that now is affected because of the scarring process that even causes maybe this more pronounced pain when the penis is trying to become erect, or in the act of trying to have intercourse, that you can feel it's even more hurtful to the penis during that act.
So if you suspect anything like that might be an issue, isn't it best to say it's best to immediately seek a healthcare provider at that point?
Well, you're referring now to what action can be taken.
Exactly.
And, for the listeners, I would certainly support getting this evaluated. This is something that can be brought to the attention of a regular physician as well. And then if need be, yes, come find a urologic specialist to discuss this. Now, the reason for that is to make sure that we're identifying the condition properly and reviewing how we can go about taking action with it. And there's management approaches that do bear some discussion that we can get into, but at least confirming that this is the correct diagnosis, and then reviewing your management options would be next.
Sure. And what might be it misdiagnosed for? Is there something a similar condition that it might be and not Peyronies?
Well, any kind of other disorder of the penis that could have more implications needs to be distinguished from this. Peyronies, as you're hearing, is a benign scarring process, almost like an arthritic process that is occurring in the penis. What can be distinguished from it is something could be more serious, like a penile cancer, but this is not what this is. A penile cancer, malignancy, is usually something that has lesions that are observed on the penis.
Sure.
So this is separate from that.
Yeah.
But to make sure that at least for the person who's experiencing the condition, that distinction is important. Okay, but for us clinicians, we can almost immediately and readily distinguish a penile cancer from this, because this is really scar tissue within the penis. Yeah. But actually seeing somebody who's familiar with this as a clinician can help reassure the patient that is not what this is. This is not a penile cancer or some other kind of more serious condition of the penis.
How many men have this disease? Is it something that's growing more popular from what you can gather from maybe data or even anecdotal experience? How many men have this disease?
Well, it's great that you mentioned that, because this is really not a rare condition at all. Now, yes, it's kind of a taboo subject, something happening to a man's genitalia. It's not really something that really gets frequently discussed in a dinner table conversation or something like that. Yeah. But believe it or not, this is a very common condition that we think can affect in a range of 3 to 9% of men. Okay, so it's virtually 1 in 20 to almost 1 in 11 men out there. It commonly occurs in men in the 50-year-old age range or so. And that makes sense, because it's almost like it's a condition or a process of wear and tear. Things break down a little bit by the time you get to be that age range, and the penis does sustain perhaps lifelong activity sexually, and changes in it where this scarring process develops. And again, I use the analogy of the arthritic knee, the knee with arthritis, if you will, that as people live a few decades of life now, some will start to get arthritis of joints and things of that sort. So we see this commonly. Overall, you heard a percentage of men that get this. The age range that commonly occurs, although we may see it even in younger men. I've seen college students who may start to have some structural breakdown of the penis.
But that would be more rare than someone, say, in their 50s.
Absolutely. Okay. So the most common range is guys in their 50s. And we see guys somewhat later in life, and we think the process does have a genetic component. That is, it's not everybody's afflicted. And just like all of us are going to have different conditions and diseases that affect us, that may have genetic associations, we think that this is a condition that results from a traumatic effect to the penis combined with a predisposing factor based on somebody's genetic makeup, their body makeup, whereby that person has a greater likelihood of having this developed. Yeah. And in fact, now we do see this happening sometimes in families. Somebody else in the family has had this sort of condition and may have a similar sort of thing. We see this in conditions where people having scarring processes elsewhere in the body, such as contractures in the hands. We call these Dupuytren's contractures, scarring at the soles of the feet, called Lederhosen disease.
Could be linked to Peyronies, this type of thing.
These have been linked to Peyronies. So the point being is that there may be some sort of genetic basis that we are starting to investigate and decipher that may predispose certain individuals to have scarring in the body, to be predisposed to developing scar tissue and kind of arthritic kind of changes and scar tissue changes, if you will, that may occur in one individual but not another one.
Are these recent things that have come to light from maybe new studies or something? How much research is out there on this disease?
Well, you ask about research and how much are we giving attention to it. I know that this is something that is not new. It's been known for centuries. It's been known. It's deserves more research attention, I think, now. Perhaps it has gotten poor attention in the past, in part because this is a condition that is a bit of a taboo subject. That people don't talk about their genitalia, they don't talk about conditions relating to this. But I think we've seen, perhaps in recent decades here, a greater acceptance of the importance of one's sexuality, of all aspects of the body, particularly in the urology field. We recognize sexual function is still very, very important. And we've had innovations in the field to help bring new therapies in the area of sexual medicine overall. So maybe that's getting part of the attention here. But again, this is a process that's not cancerous. It's been a taboo subject in the past, so maybe it's getting more attention among the general public. But among clinicians in urology, we've known about this condition for a long time, and it does deserve more research attention to address it and develop therapies that can help us manage it.
Okay. Now let's talk about treatment. How is it treated? Does it depend on what stage it's at that you discover it at, or what can you tell us about the treatment of it?
Well, the treatment of Peyronie's disease largely is not very well developed, and much of it comes down to reassurance for the patient. As I mentioned, that there is this psychological overlay, so that's a strong aspect of working with patients who come in. But in terms of actually addressing the condition itself, which is key. Now, we address the condition, and it'll help alleviate some of the psychological distress and bother that's associated with it. And that's really the crux of the matter. What do we have scientifically? What do we have that's evidence-based, that is based on scientific evidence, that can really treat this condition, lessen the scarring tissue, allow the penis to be a bit more normal, both structurally and functionally? And the answer is we're still struggling to offer great therapies. I can tell you what we have to offer. Early on, in the early stage of the disease, we generally recommend pain-relieving treatments, principally because of the pain that's predominant in that early phase of it, the active phase of the disease, prior to its stabilization or the later stage stable phase of the disease. So having the condition early on, alleviate your pain with non-steroidal anti-inflammatory drugs. That would be a recommendation. Of course, there are many things out there that are being offered that we have early on in urology suggested, but we're now really questioning whether they really are scientifically based and based on really good evidence of effect. So we started to back off on things that we historically had offered, such things as vitamin E, Potaba, various other kinds of vitamins and things like that we really are suspicious may not be that helpful. So reassurance is key. Pain relief, I think, in the early phase of the disease is key. And accepting that this may have a natural history, that we'll have to see how it resolves in some, but not everybody in time. For those who do go on to the more stable phase of the disease with a more pronounced curvature and inability to perform sexually, then we have to get ready to step up there with what can we offer. If the erections are poor, we have what's established as effective oral therapies in the form of sildenafil and vardenafil and tadalafil, avanafil, all the oral, what we call PDE5 inhibitors to help with the erection response. As far as the angulation is concerned, then we have to decide what can we offer here that will now allow a person to have let's say, a straighter penis for sexual intercourse. And the interventions range from injectables to surgical treatments. Now, there have been therapies that we call topical therapies placed on the penis as ointments or salves or creams.
What's salves?
Creams and things like that. Those kind of things. And those sort of things haven't really borne out to be that successful at this point in time as a proven therapy. We call these topical therapies. That would be nice. Something that's fairly non-invasive, an oral pill or an ointment or cream put on the penis. That would be ideal. Because these other things I'm talking about that are surgical procedures or injecting things in the penis, these things are a little bit more invasive and may not appeal to everybody. But the success of these things, these other interventions, may be somewhat greater than the lesser invasive options that may not have much success to help the condition. The injectables that have been discussed out there range from an FDA-approved medication called Xiaflex, which is an agent that allows the breakdown of scar tissue. So it's a collagenase, big word there, that refers to an enzyme that breaks down collagen, which is the fundamental component of scar tissue. And it's injected in the penis where the scar tissue is, and the penis is modeled or bent to try and release scar tissue with a series of treatments over time that has some efficacy, and the FDA has approved this as a way of treating this scar tissue in the penis. There are other things that are out there that have been offered in the past. Injectable verapamil, injectable interferon. These are other treatments that are not quite as well established in terms of guideline statements for their use. The real injectable that we would promote as being a first-line injectable would be this intralesional or injectable collagenase, and going by the trade name Xiaflex.
And that breaks down the scar tissue?
Breaks down the scar tissue.
Is the scar tissue the same thing as the plaques that form?
Well, we use the word plaque now.
Okay.
And I'm referring to the same thing. Okay. The scar tissue is the plaque is the scar tissue.
Gotcha.
But the thing that needs to be clarified for the audience here is that we're not thinking about plaque like we somehow visualize this with the TV commercials and blood vessels that just this kind of this thick-looking yellowish sludge that occurs in blood vessels. That we kind of think that's what plaque's all about. Here we're talking about, even though we use the word plaque, it's really scar tissue that may be almost seen on the skin with keloids and things of that sort, but deep in the penis, there's scar tissue where the tissues kind of congeal together and create this thickness, and that scar tissue is what we're talking about. We use the word plaque, but that perhaps is a misstatement. We should be just saying this is scar tissue. Now, beyond the injectables, just to go a step further, we talked about surgery, and I just want to make sure I round out the rest of the discussion here. Again, surgery it obviously is much more invasive than other options here, but it is part of the menu of options that we will bring to patients who may have a very significant deformity that disallows sexual activity. That patient may not elect to do any kind of injectable therapy here that may have modest effects. They may fail these other therapies. And so we do have this option of going in and surgically releasing scar tissue, straightening the penis. And that does require expertise of a urologic surgeon to implement this therapy. So that has high success rates by and large, and we carefully select patients based on clinical presentations of the degree of angulation, the extent of the erection ability or inability. Because the additional remark here is if somebody has a deformity and erections are quite poor, that patient may be best served with a penile prosthesis surgery, not just straightening alone. Because if we just do about a surgical straightening procedure and the overall erection ability is not good, we more or less have converted that man to a straighter and perhaps more normal looking penis. But if he's not very functional, then that's the problem. So we have to make sure that we acknowledge and address the entire aspect of the structural problem and functional problem to allow that man to be functional again using his penis for sexual activity.
Yeah, it sounds like there's a lot of variables at play, but what kind of life is someone in store for after treatment?
So what do we look for in a person after treatment? Well, we have the expectation that we are restoring some level of functional ability, if not normalcy, entirely to that patient.
Are you talking sexually?
Sexually.
Okay.
In terms of what the penis is made for. Yes, the penis is a complex organ. It's there for urination and so forth. But part of it is for sexual activity in the adult male. And being able to have a straighter penis, have a penis that can be functionally able to achieve an erection. These are the goals that we'd like to achieve for that patient. And restore his sense of manhood and a sense of calm and peace that he's not psychologically distressed about this whole thing. So I think we do want to achieve these goals for that patient.
How about urinary symptoms?
Well, with regard to urination, that really is not associated with this disease state. It's really, the scar tissue that develops in the penis really is unassociated with urinary difficulties. Now, some men can have a major trauma to the penis, may have had some injury, maybe with a catheter inserted in the penis, which is a kind of a tube medically for draining urine. Maybe something was done very traumatically there, and that really did a kind of a damage to the urethra. That's the urinary tube, the urethra within the penis, and that's causing the deformity. And then there's urination issues that relate to a stricture or scar tissue in the urethra with a deformity there. But that's kind of a different kind of condition than Peyronie's disease that we think of as scar tissue that really is associated with the structure of the penis has to do with erections separate from the urethra.
Sure. So, broadly speaking, after treatment, there probably won't be any urinary issues.
That's correct. When we go about addressing Peyronie's disease, urinary issues should not be affected by the interventions that we bring.
Sure. Always exceptions to the rules, though. Well,
anything could happen, but uniformly speaking, whatever we're offering, including surgery, should not alter a man's urinary abilities.
And I just want to touch on the psychological or emotional factors. Do you have any thoughts on that?
My thoughts about that is that we professionals in this area of managing Peyronie's disease do recognize and certainly try to share with our colleagues, those of us who are very specialized, what we've known all along, that there is a psychological overlay that's related to this condition. And why not? Why wouldn't there be? If a man's having a significant change in his genitalia, a man can be distressed about that. So it's common to have some distress with having deformity of the penis, as I'm describing it here, with this very common condition. And so know that the message, I think, is to acknowledge it, to address the problem, but also provide that support to that patient or the couple, that man and his partner. That we do support therapy if needed with regard to addressing the condition. So I think that's the message that I would convey, that we acknowledge the seriousness of the psychological impact, and that should be part of how we're managing the problem.
So before we wrap up, is there any final thoughts you'd like to get out there about this disease?
I think we've covered it very well. I mean,
Sure.
to acknowledge that this is something that's common and action can be taken, and that we really still do need to make progress in this field to bring good therapy. I mean, ideal therapy would be something that's lesser invasive, that's very effective.
Sure.
And we still have a ways to go to do that. We do have a range of therapies that I think are established, and we have to bring the right therapy to the right patient depending upon that patient's actual clinical presentation of their Peyronies disease. But we have action that we can bring, and interventions that can be offered. And I don't want a man to suffer out there, thinking that this is a unique problem for him and nothing can be done. That's just not true.
My guest today has been Dr. Arthur Burnett of Johns Hopkins Hospital. Dr. Burnett, I can't thank you enough for coming on and giving us all this incredible information. Thank you.
It's been my pleasure, Casey.
This podcast has been brought to you by the Urology Care Foundation, the official foundation of the American Urological Association. For more information on today's topic and for all things urology health, visit urologyhealth.org.